Okay, thank you. Sorry about the interruption. So I'll go to the lupus. This is one of our study which we looked at mycophenolate and deflazacort combination in neuropsychiatric lupus, and we looked at our experience over a decade in southern India, and we carefully chose the neuropsychiatric lupus fulfilling the ACR criteria, and in our cohort, the seizure was the commonest manifestation in about 42% of new NPSLE. And what was interesting was that the MMF gave overall a very good clinical response, and also he gave significant lesser toxicity when deflazacort was used compared to prednisolone, and it was safe and efficacious in terms of preventing relapse. So this was the first ever study in NPSLE to document the mycophenolate's efficacy. Uh, this is another study where we looked at a very unique way of giving pulse cyclophosphamide. People who come from interior, sometimes coming for even IV cyclophosphamide pulse involves hospitalization, intravenous injection, cost, travel, and other complications. So we designed a way of giving the same dose of cyclophosphamide which you would be giving in intravenous in three divided doses from day 1 to day 3. Say monthly pulse means we give, suppose 750 milligram, we give 250 milligram day 1, day 2, and day 3, and repeat after 1 month. After 4 cycles or 6 cycles, switch over to 3 monthly. And this was found to be having oral pulse cyclophosphamide. This was the first ever use, and we found it is efficacious, cheaper, and actually less toxic compared to IV's pulse cyclophosphamide. And this is an interesting observation. We again did a non-concurrent cohort study where we did co-trimoxazole prophylaxis to prevent major infective episodes in lupus patients. We used majority was given daily double strength co-trimoxazole, but a few are given also 3 days a week. But majority were given daily. And what we found is the people who received almost had no major infection compared to who did not have co-trimoxazole prophylaxis. So co-trimoxazole prophylaxis not only prevents PCP infection, but also prevents other major infections. By major infection, what we meant was hospitalization or a patient requiring intravenous antibiotic. So this was another clinically relevant study, and as you can see, the incident densities of the major infections per 100 years was significantly lower when the prophylaxis was given compared to no prophylaxis. This is another head-to-head comparison. We looked at the efficacy between high-dose deflazacort versus high-dose prednisolone. As you know, deflazacort is a metabolite of prednisolone, and deflazacort is little expensive than prednisolone, but its safety in terms of metabolic side effects are very high. And we actually studied this in a prospectively designed cohort study. And there was comparable intake and tapering of high-dose deflazacort and prednisolone in active SLE. It revealed there is a 2-fold less weight gain, 2.5-fold less hirsutism, and 1.5-fold lower Cushingoid severity index, as well as lower glycemic elevation in the deflazacort group as compared to prednisolone group. Both had similar efficacy. So this is something for the first time again. So this was the design of our study. And this is another observation in lupus. We studied familial aggregation. You know that it's a very common experience to have lupus patients and even other autoimmune disease patients to some extent have familial aggregation. So we actually studied the up to 3-degree relatives and look for familial aggregation of autoimmune diseases. And SLE was the commonest autoimmune rheumatic disease seen in families of 19 patients in a familial prevalence of 12.1%. And also autoimmune rheumatic disease as a whole and SLE alone were seen more commonly with parental consanguinity. And rheumatoid arthritis was the second most common autoimmune rheumatic disease seen in 41% of the families with a relative risk of 3.1%. So South Asian or the Asian Indians SLE patients seem to have a high familial aggregation of autoimmune rheumatic diseases, which is more pronounced in the background of parental consanguinity. SLE is the commonest AIRD seen amongst FDRs and SDRs, the first degree relatives and second degree relatives of SLE patients, followed by rheumatoid arthritis, with the FDRs being at highest risk. So first degrees being the highest risk. So this was a study of comparison with various other series from different countries, from US, from the Gladial cohort, from Taiwan, Denmark, Brazil, and our cohort. And there have been a variable prevalence of the familial aggregation. So we just wanted to show that we have our own data now of our own population. Now, this is another interesting study where I looked at in patients with seronegative antiphospholipid antibody syndrome, and we did a PSPT or anti-phosphatidyl serine prothrombinase complex antibody. It outperformed all classical antiphospholipid antibodies in diagnosis and classification of obstetric APS, and both isotypes of beta-2 GP1 antibodies in clinical diagnosis or classification of APS. APS-PT could reclassify additional 12.1 and 42.8% of patients as APS overall and in obstetric APS respectively. So over and above the cases satisfying the revised Sapporo criteria. It means that the obstetric APS, it has a very high significance. So this is the APS overall and the obstetric APS. We can see the percentage of patients diagnosed with APS in relation to various APLS, and here on the right side is showing the sensitivity and specificity of the PSPT and the total number of patients, and the last row also depicts patient for each initial impression. The first column depicts the number of patients with initial impression of primary Sjogren's syndrome. So you can see that the rheumatology and again the general medicine is the distant second in terms of picking up Sjogren's syndrome from a wide range of diagnoses made by presentations made by the patients in going into different specialties. Now, we also had identify a unique biomarker looking for serum kappa and lambda free light chains, and it was found to be significantly higher in Sjogren's, especially in those with ocular symptoms, and serum and salivary free light chains, and in particular in the later are potential biomarkers in Sjogren's syndrome. This is also an interesting study. Unlike you know that all of us have a low vitamin D state in South Asia, and in rheumatic diseases it is more. But surprisingly, in Sjogren's syndrome, the vitamin D deficiency or insufficiency is not more than that in the normal population. So that was another interesting observation. So after our series was published, we had a call from the Sjogren's Big Data Group, and they included us, and we are part of the Sjogren's Big Data Group. So they have accepted same like ours, that there's much higher female to male ratio, and the prevalence of sickness symptoms is lowest among the Asian patients. So this is another message for us, and I think it was very nice that they have indicated our stand. There's also from the same group, more than a quarter of patients with primary Sjogren's syndrome may have systemic manifestations, not concurrently included in the ESSDI classification. As I have told, about 1/3 of our patient cluster analysis had systemic features like vasculitis, RTA, etc., whereas 2/3 had only general features, non-systemic. So they have also accepted that. This publication was also done by the Sjogren's Big Data Group. So then this is about an interesting study, the incidence of a higher breast cancer rate and complications and death in Sjogren's syndrome patients in Asian population compared to the Caucasians and others. So this is a very interesting observation, because Sjogren's affects exocrine glands. So this is not very unusually, it is not unexpected, but this shows that we have a much higher prevalence of breast cancer in Sjogren's patients. Now about IgG4 disease, we are one of the first to use mycophenolate along with steroids. And we found that in terms of IgG4 responder index, patients on mycophenolate as a second-line agent could help in tapering steroids faster, because many patients could not afford rituximab those days. Now it is cheaper because of biosimilar, but even then, so mycophenolate may be a good steroid-sparing agents, which helps in successful tapering of steroids while maintaining the improvement in IgG4 disease. Now about myositis, we published outcome data with a large South Asian cohort, and we had 232 patients, the median follow-up of 44.5 months. ILD was seen in 40% of the patients. Absence of pericardial effusion and presence of Gottron's rash at baseline predicted the complete remission by multivariate regression, and majority received mycophenolate during the entire follow-up period. Discontinuation of steroid was feasible in 51% after a median of 24 months. And the flares are numerically lesser in patients only on mycophenolate compared to those only on methotrexate. So mycophenolate is an effective treatment option in inflammatory myositis patients, even without coexisting ILD. Now about our study, we have two interesting studies in scleroderma. So we have reported a unique clinical and autoantibody profile of a large Asian Indian cohort of scleroderma. Do South Asians have a more aggressive disease? So we found that there was a younger age of onset and a high prevalence of SCL70 antibody. These are both unique to South Asian features and common with large Indian, Thai, and Chinese studies also. High prevalence of interstitial lung disease is a feature common to Indian and Chinese series, and strong correlation of SCL70 antibody with younger age and pulmonary hypertension were unique features in our cohort. So this is showing the graph showing the from the skin, Raynaud's, breathlessness, digital scars, and various clinical features in decreasing order. And here it shows the prevalence of the organ involvement on the right side in our cohort. And asterisk means the digital ulcer. digital gangrene, and digital scars. So this is the presentations in our cohort. And this is a comparison of our cohort with series from another Indian cohort, Japanese, Caucasian, Hispanic, Black, and Chinese. And we have mentioned what is unique in our patients, that we seem to have more of SCL70, more of ILD, etc., in our patients compared to other cohorts. And this is again a study of outcome of mycophenolate and scleroderma associated ILD, real world data from rheumatology and pulmonary clinics of South Asia. So in our referral center, we have found that mycophenolate mofetil or mycophenolate sodium was efficacious in improving or stabilizing FVC, irrespective of the baseline high resolution CT lung score in our patients with systemic sclerosis related ILD with a duration of more than 2 years. So this is showing that the absolute change from FVC, the below here, the positive improvement, and above is the negative or worsening. So you can see the positive improvement is far more than the people who had worsening in terms of number of patients here.
Thank you so much,
And
Dr.
I'll just take last 5 minutes if you permit me. Uh, so this is a very interesting study from Delhi on from the genetic database, and it found that there was a 20 pathogenic and likely pathogenic variants founded by founder mutation, comparing the various other series, that very high prevalence of autoinflammatory susceptibility genes in our population. So it must be the same story in Pakistan too, and they have studied using the various databases and various population. They have compared, and they have looked at the benign, likely benign, pathogenic, and likely pathogenic. So approximately 4.2% were pathogenic ones they have found, and they have compared this with databases from European, American, South Asian, American, Sub-Saharan Africans, Arabs, various populations, and they have found there's a higher prevalence of these genes in our population. And this is again showing various ethnic population, and they have found the chromosomal painting showing that there was a significantly higher prevalence of few selected genes, which are susceptibility genes for autoinflammatory syndrome. So they are basically prevalent, and the founders are mainly, some of the founder mutations are descendants from a different ancestry because of the mixing of blood in our population by invasion. And this is the last study I'm mentioning today, is Takayasu's arthritis. This is the first ever study on epigenetic studies, and we found that the IL-32 and lymphotoxin A were genes significantly hypomethylated in CD8 T cells, and anti-inflammatory cytokine genes like IL-10, IL-1 RN, and IL-27 were hypomethylated in gamma delta T cells of Takayasu patients. Genes involved in T cell receptor signaling pathways are hypomethylated in CD8 positive T cells and hypermethylated in gamma delta T cells of Takayasu's patient. So this is a very important thing, and the heat map showing that the hypomethylation of the genes in CD8 positive cells and gamma delta T cells and the specific genes which are lighted up for hypomethylation in gamma delta T cells, and some are in CD8 positive T cells like CCRL2 and CITA genes are also hypomethylated in gamma delta T cells. So this is again showing the picture of hypomethylation of genes in cytotoxic T cells and hypermethylation of the genes in gamma delta T cells, which are relevant in terms of etiopathogenesis, that is basically environmental pressure, infection, etc. Genetic modifications in Takayasu, and Takayasu have been long suspected to have some relationship with infection, including tuberculosis. So the take-home message here is that South Asians have unique features in terms of geoethnic and socio-cultural dimensions of rheumatic musculoskeletal diseases. So this will be worth replicating in all our South Asian population. Thank you very much.
Thank you very much, Dr. Danda. It was an excellent talk, and something that both our countries share. I have a few questions for you, but in the interest of time, I will be posting that questions. And I would appreciate if you could reply probably online via email, and I'll pass it on to the participants who have asked me these questions. Thank you so much.
Sure, sure. Thank you for the opportunity.
Now I would request Dr. Mahitalat to please come to the stage to present her case for a discussion with the professors. Dr. Laura, Dr. Sami Salman, Dr. Hasni, to please come to the stage and contribute towards the Meet the Professor session.
Can we have some sound? Oh, here we are. So this is what it's all about, really, isn't it? It's about education junior doctors, and going through the learning process. So this isn't called Trick the Professor. My next lecture is Trick the Audience. But we're going to hear some lovely cases, I think.
Assalamu alaikum. I am Dr. Mahitalat, resident internal medicine, currently working in rheumatology department, Shalamar Hospital, Lahore. Today I am going to present a case of a 43-year-old female, married with 5 children, history of 3 first trimester miscarriages. She presented in rheumatology OPD with chief complaints of a small swelling on right jawline for 1 month and fever for 15 days. My patient was in usual state of health 1 month back when she noticed a small swelling on her right jawline 1 month back. It was gradually increasing in size, associated with pain that worsened on jaw movement. Pain was radiating behind the ear and in the neck. There was no relieving factor and the swelling was not responding to antibiotics. She also had history of fever, which was low grade and undocumented. She had a background history of headaches for the last 4 years, which initially she had 1 to 2 episodes per month, and they aggravated in the last 1 month with 1 to 2 episodes per week, associated with photophobia, phonophobia, and occasional episodes of nausea and vomiting. Her review of systems were unremarkable for seizures, vertigo, altered sensorium, limb claudication, DVT, stroke, or any cardiac event. In her past, she had dengue fever and she developed bilateral loss of vision post-dengue, which restored after 3 months of taking some medication, of which the record was not available. On clinical examination, a middle-aged woman, cooperative and conscious throughout her examination, her pulse was 75 per minute of regular rhythm and normal volume, bilaterally comparable with no radioradial or radiofemoral delay. All pulses were palpable. Her blood pressures were comparable in both upper limbs. She was afebrile and was maintaining her saturation at room air. On examination of her face, she had bilateral maxillary sinus tenderness. There was a 2 into 2 centimeter over nodule over the right jaw, which was firm in consistency, mobile, tender to touch, not adherent to underlying bone, and overlying skin was pinchable with a biopsy scar. Her rest of systemic examination was unremarkable. Her initial baselines were unremarkable. Viral serology, including hepatitis B, C, and HIV, was negative. However, her ANA profile by IFA was done, which was positive with a titers of 1:160 having speckled pattern. ENA by Contrix showed anti-Rho SSA and anti-Rho 52 strongly positive. Her complements were normal and her ANCAs were negative. Her TSH was lower limit normal with mildly elevated free T4 level, and thyroid scan showed early manifestations of multinodular goiter. Her MRI brain, face, and neck showed minimal atrophic changes in brain parenchyma, bilateral maxillary sinusitis, and enlargement of right lobe of thyroid. Excisional biopsy of the swelling was done, which included a segment of muscular vessel showing prominent lymphocytes, multinucleated giant cells occasionally present, focal disruption of internal elastic lamina, fibrinous exudate, and active necrotizing vasculitis. Our probable diagnosis on the basis of biopsy was Sjogren's syndrome. During her hospital stay, she was given, okay. Patient again presented 1 week later with abdominal pain, loose stools, multiple episodes containing blood for 3 days, which was not responding to antibiotics, gross hematuria, and no association of fever. This time, her labs showed +3 blood and numerous RBCs. Rest of labs were unremarkable. Her CT angiography was done to rule out mesenteric vasculitis, and it was unremarkable. She was given methylprednisolone, and her hematochezia and hematuria settled after 48 hours. She was then discharged on delta-cortil, mycophenol, HCQ, along with hematinics. Thank you.
Thank you so much, Mahitalat. So basically, from what we wanted to learn from all of you professors was that this was a case that was sent to us by the surgeons who were doing an excisional biopsy of a lump on a jaw. And when the pathologist saw the slides, they said that it is vasculitis. My question to all of you, and especially Dr. Exford, was that how common do you see vasculitis in Sjogren's syndrome?
Can we just go back a little bit? The biopsy wasn't from the thyroid, was it? The biopsy was from a discrete lymph node.
Yes.
Yeah, or gland.
Yeah.
Okay, so the thyroid had nothing to do with it. You didn't tell us what her ESR and CRP were.
They were mildly raised. They weren't like, you know, totally.
They were raised?
They were mildly raised, yes.
Right. And so I think the important thing is to differentiate whether the ENA and the weakly positive ANA had any relevance at all to her presenting complaint.
Initially, when she came to us with medium vessel vasculitis, we were thinking more along the line of like a pan or something like that, having medium vessels. So we went out for the serologies. And then the next diagnosis that we had in our mind was that is it like an ANCA vasculitis with a going on to a medium vessel vasculitis, but that wasn't the case. Then there were the giant cells we could see on the biopsy. So another thought that came to our mind was sarcoidosis. By chance, somebody had already sent the ANA, that wasn't us, and it came out weakly positive. So when it came out weakly positive, we sent for the ENA, and that was positive in high titers. So it is the first time for me, at least, having a Sjogren's with vasculitis. So I would like your input on the case. What would you think? How should we have proceeded with this case?
I'll let my colleagues say a few things, but I'm not sure that the biopsy is representative of Sjogren's syndrome either. So I've got a few other ideas. It looks like a lot of histiocytes, but Laura, I don't know what your thoughts are here.
Yeah, it is definitely a confusing clinical picture. I didn't hear anything in the history about Sjogren's symptoms, so I don't know if that was asked in negative, so no dry eyes, no dry mouth, like fatigue or things like that, no. Yeah, I think, in a lot of these cases you can have mildly positive ENAs, but it's not a clinching diagnosis, and I think I would think more about what you're seeing on the biopsy and her other symptoms. Do people think that her previous history of vision loss is related to things that are going on now, or was there any kind of digging in? Because I have taken care of dengue a few times, but that vision loss I haven't ever had experience. Is that common in dengue or is that uncommon?
Basically, she had an episode of a sudden visual loss postpartum, and I'm not sure whether that was what the relevance was that just a red herring. The only thing, other biopsy that we had on her, she was suffering from epigastric discomfort for a very long time. And somebody had done like a duodenal biopsy, and all they could find was lymphocytic infiltrates at that time as well. And even in this biopsy, it was a predominantly lymphocytic infiltrates that we could see with giant cells, but no granuloma formation. So for that reason, I was wondering, should we suspect it as Sjogren's, or what should we suspect? I would like Dr. Hasni, your opinion on it as well?
Well, Sami, I've got a few ideas.
Okay. Yeah, so I'll wait for you to say something. I used to run Sjogren's clinic at the NIH, and I think her presentation and the biopsy is not very consistent with Sjogren's, though. Okay. I think if you do some of the special stains on the biopsy, maybe looking at some immunofluorescence and also the special T cells and B cells staining, that might be helpful. I mean, the other option is that you have sent ANCAs, or all of them were negative?
ANCAs were negative.
ANCAs are also negative. So. All right, Sami, I think you're saying something, so.
This reminds me with when I first arrived to Britain, and I had to have a blood test, and they showed me an X-ray of chest with a rounded mass, and the examiner said, "What do you think?" I said, "In your country or in my country?" And I said, "In your country it will be a CA. In my country it will be a TB." I'm thinking of TB, to be honest. Multinucleated giant cells. In TB you get positive antinuclear antibodies. You might get even positive ENA. You get lymph nodes. You get fever. It is endemic in many parts of my country, and probably in the area where this girl comes from. And I would rather consider tuberculosis more than considering sarcoidosis in such case. And I don't know if you thought of tuberculosis in this, especially she doesn't have many symptoms of Sjogren that go with Sjogren. This visual loss might be a red herring, as you said, and I think it is, because it's not witnessed. It is something belongs to what she says, and you never know if it was a real thing or not. So I would really think seriously about re-examining her slides for her, specimen, and looking more deeply for possibility of tuberculosis.
So
I know it is a wild thing, but this is what I would have thought in my country.
So I think what we're getting at here is are the blood tests and her previous history of any relevance to her presenting features? And I think probably not. And I think this looks like a discrete episode of acute inflammation. What I would say to Sami is, if this were TB and she was treated with IV methylprednisolone and immunosuppression, would she have got better?
Excuse me, sir.
And just to move forward a little bit, what we're looking at on that biopsy are lots of histiocytes. And I just wonder whether this is necrotizing histiocytosis. and that's why she's got acute inflammation, fever, and it seems to be resolving. So that's otherwise known as Kikuchi's disease syndrome.
Sir, her TB workup was done. We also went for TB gene expert. It was negative. And when we discussed the biopsy with the histopath department, they specifically mentioned that they were not very convinced about multinucleate giant cells. They were just occasionally present, and main feature was active necrotizing vasculitis.
And then she was given multiple courses of antibiotics, to which there was really no response, and we gave what we give best, steroids, and her symptoms resolved. But the following couple of weeks, she came back with RBCs in her urine and proteinuria as well. So we are now have put her under immunosuppression, thinking of some sort of autoimmune disease that is affecting her.
Are you going to be able to biopsy the kidney?
Sorry?
Will you have the availability to biopsy the kidney to get more
We
information?
are planning on her kidney biopsy, yes. So that we can have a more like a confirmation on what are we dealing with exactly. Thank you so much. Now we will move on to our second case.
But just one thing, I think one of the issues here that I find quite a lot is you get a patient like this, you decide what your diagnosis is, and your diagnosis was autoimmune disease, and then you move on, and this lady ends up probably with a self-limiting disorder on mycophenolate, and I just think you need to reconsider that, because it's quite easy to decide upon what your diagnosis is, fit everything into that, and then you move on with quite heavy immunosuppression.
Okay, thank you so much, Dr. Axel. Now I will be presenting the second case. My registrar rheumatology, Dr. Faiza Naeem, will be presenting this case, and it is basically concerning juvenile patients. Thank you so much.